recognize you. You've been such an excellent person. Thank you, Dumsani, and they are my strength. We have Fabian, who was here with us. He came in to work briefly with us here, but returned back to continue to work with us. And such an excellent guy, excellent young man. We also have the Robert Koch Institute. We've been working with them. I think they are here, and they've been supporting us. One of the partners that we've really enjoy working with, and right now supporting us with a lot of things. Adela, did I miss anybody? Yo, Jerusalem, yes. Thank you. Jerusalem is one of the our staff members that supported. I don't know how I missed it. Thank you, Dr. Ahmed. Let me hand over back to you.
Yeah, Ramwanda, thank you very much for sharing in detail that process that resulted in the very advanced draft of the strategy for NCDI and mental health that is before you. I think the key message I take away from this is it has been very, very consultative within the union, outside of the union, within public health, outside of public health. It has been very, very consultative. And in this way, we can say that the final document is going to accommodate as much of what needs to be done on the continent as is possible. Now, let me shift to partners who are with us and have been part of this process for quite a while, we would like to say, to make a few comments before we go on to the other presentations that we have. So I'll start with the WHO, and I'll call upon Bente. Bente, I think you are online. If Bente, you could be able to make the first intervention, and please do introduce yourself. I may not do justice to that. And then we will go to Afro and Emro within the WHO family before we go to other partners. Bente, you have the floor.
Thank you. Thank you very much, Dr. Ahmed. It was so good to see you, honorable ministers, excellencies, and Dr. John Nekansong, colleagues and friends of NCD. I'm really, really happy to be with you today, and thank you to African CDC and African Union for inviting me. Just the fact that you are validating and launching the Africa CDC NCD disease injuries mental health strategy is such a welcome pleasure. We are really, really amazed. And I think the pure fact that you are inviting us as well, recognizing our partnership in the prevention and control of NCD injury and mental health in Africa is so very, very nice. And of course, we all know that the support for NCD and mental health and injuries have too long and too often been ignored and neglected. And this, even in a region like African region, where you particularly feel the burden as the premature mortality from NCD across all African countries are among the highest globally. And we know that the estimates should suggest that it's causing over 2 million premature deaths and 204 million disability-adjusted life years lost across Africa in 2019. I have with pleasure and interest listened to the former speaker and also the huge, very involving process to come to this strategy. And we are also happy to be part of the review exercise. Of course, we all know that the NCD burden is driven by rising prevalence in the modifiable risk factors like tobacco, harmful use of alcohol, physical inactivity, and unhealthy diet, and also environmental pollution and air pollution especially. But I think what we have really seen and cannot anymore ignore is the weak health systems. As we have seen in all parts of the world, COVID has been like an X-ray. Over 70% of all the member states of WHO have reported, even though late last year, over 70% of the countries with disruption, up to 50-60% in all the major NCDs like cardiovascular diseases, diabetes, cancer, and lung diseases. So what we saw was that it was not even the very dire fact that people with the NCDs had higher risk of the disease during COVID, as in other pandemics as well, and the risk of dying. But it's also that we have a big backlog now. People got undiagnosed, untreated, and unprotected. On the good side, and I have heard with also interest and pleasure that you have discussed now innovation, of course, implementation research and learning journeys like communities of practice and so forth. And I think we can learn a lot from COVID. What we saw was a huge digital shift. We saw telemedicine really coming into the new health system models. We saw the rise of self-care. We saw task shifting and, very interestingly, new procurement mechanisms and access to medicines and devices for people living with NCDs. Africa are not on track to achieve the SDG 3.4, namely 1/3 reduction in premature mortality from NCD by 2030. And as you have said today as well, significant acceleration is necessary and important if we are going to, prohibit more preventable suffering in African countries and in the world. And I hope you recognize as well that under WHO's leadership, both globally and in partnership with the regional and country offices, we aim to support member states with technical support that is so much requested. Actually, I can disclose to you that when we looked at the country support plans developed for WHO in the last biennium, NCD was among the highest ranking requested support areas, and especially the integration of NCD into UHC and the strengthening of primary health care. On the bright side, you know, and I know that is reflected in your document as well, that we have developed the best buys. So this is affordable and accessible interventions that can be used for countries. And by using them, we will be able to reduce the premature mortality and reach the targets. And we have a lot of packages, which is built on the same, like Empower for tobacco, Shake for salt, and Hearts and Pen, and also the Global Diabetes Compact for diabetes. So many initiatives exist. So it is actually no excuse for any of us not to prioritize these interventions. And they harmonized and align also to a great extent with what was just a run through of the prioritization and the feedback from the region itself. So you have earlier today also listened to our colleagues from the UN Interagency Task Force speaking about the Multi-Donor Trust Fund. And we also have the global coordination mechanism within WHO that can support in multi-sectoral action. But this is also something that WHO in total are supporting very much. So I will just mention a couple of more things. I'm sure that you are eager to move on in your program. But since we have seen only 14 countries globally so far on track to reach the SDG 3.4, the member states of WHO decided during the World Health Assembly in 2021 to ask the Secretariat to draft an implementation roadmap from 2023 to 2030. And through the executive board, this was approved for discussion in this year's World Health Assembly. And what we are building on is, again, what you have been discussing today. It is to have a national strengthened idea about epidemiology feasibility and apply the global measures at country level. It is to there, and the need is there, to prioritize the actions that is possible. And very importantly, it is to strengthen the surveillance and monitoring and utilize as well the data that exists already. So what will happen next from WHO side is that we will provide you with simulations tools that can be used for the prioritization exercise. We will also support you with different frameworks for engagement with people living with NCDs, also how to deal with the private sector. And we will also update the best buys and other recommendations that will be provided during the next year. And this will be completed in the end of 2022, but it's not like we need to wait. We have already the tools that we know is working. So this is more or less a refinement. And on the surveillance and monitoring, more support is needed. So many countries in the African region are due to implement new NCD population-based surveys in adults and adolescent populations. And this is really, I believe, the best starting point to make the exercise that is needed at the country level. I'll just rapidly mention 3-4 things and then I will wrap up. So I want to mention something that is very important to also include when you discuss NCD, and that is oral health. And oral health was for the first time now having its own resolution during the World Health Assembly in 2021, and also to include this in the NOMA strategy, and this is planned for 2023. So of course the African region has a pivotal role in the prevention and control of NOMA through its implementation at the regional NOMA control program in 10 priority countries. So I think this link can also be strengthened. And Africa faces an unprecedented challenges in hypertension in the region. And the good news is that for the first time in 21 years, we have now a protocol-based hypertension guideline, which make it more easy both to do the procurement, the alignment with the guidelines, and to really provide access to the medication to the region's patients. And as you know, globally, we have only less than 50% diagnosed, and those who are diagnosed are only 40% on treatment, and of those, unfortunately, only 21% controlled. So we have a way to go here. 19 out of 20 member states in the region has the highest burden of cervical cancer. And of course, I am very grateful for the strong support in scaling up the cervical elimination initiative. So we have seen that the technical support provided in many countries, Guinea, Kenya, Malawi, Nigeria, Rwanda, Togo, Uganda, and Zambia. And they are updating their cervical cancer guidelines and strategies. As well, the renewed momentum for digital health, and thanks again, your region have been very interested in digital health programs. So we have seen successfully diabetes programs implemented in Senegal, artificial intelligence for diabetes and retinopathy in Zambia, and cervical cancer and other Be Healthy, Be Mobile initiatives. So the last of these things I want to mention is the resolution on diabetes. And we have looked at the diabetes numbers in Africa, and they are unfortunately growing. And we have, again, the WHO pen and hearts that can be rolled out, and synergies can be made by initiatives from the Resolve to Save Life. So even if we have seen, especially after COVID, an interest now in more long-term seed funding from donors like Denmark, European Commission, Germany, Luxembourg, Norway and the Russian Federation, and also, of course, from Bloomberg Philanthropies, Bill and Melinda Gates Foundation, and now the World Diabetes Foundation. These are new partnerships, and we are utilizing the learning from COVID and the solution we co-create to people living with NCDs, but still there is a need for funding. And I'm also happy to report that the World Bank and the Global Fund are increasingly interested in what is happening. So when the Ghana meeting, we had an international strategic dialogue in Ghana just this month, where heads of state really decided to make a case for NCD and form a heads of states group at the highest level of heads of states and government. And thank you very much for the President of Ghana and also the Prime Minister of Norway for making this meeting happen. And they also agreed on a compact that can help us. So I will stop now, and I will again thank you to the African Union and to Africa CDC, and thank you for always supporting the integration person centered care. And I believe this is the right way to go, as well as we also need to add the granularity that the different diseases requires. So thank you very much for the opportunity, and very nice to see you, and good luck with the meeting. And I'm sure that we will strengthen the partnership as we go forward. Thank you very much.
No, thank you. Thank you very much, Bente. That's Bente Mikkelsen, Director NCDs at the WHO headquarters in Geneva. Very clear message there, and indeed, we will expand this partnership as we roll out implementation of the strategy. So now I would like to call two other WHO colleagues for their remarks from AFRO and then from EMRO. So we start with AFRO first. If you can introduce yourself, and then, is there a mic there?
Yes, Your Excellencies, distinguished colleagues from African CDC, it's actually my honor and pleasure to be part of this meeting on behalf of WHO AFRO. Dr. Bente Mikkelsen has actually made a lot of she's already summarized a lot of the issues with NCDs and what WHO is doing. However, for AFRO specifically, we know that in 2011, the Ministers of Health from AFRO agreed that NCDs was a huge burden, and we defined our NCDs not just along the lines of the 4x4, but NCDs in AFRO also included hemoglobinopathies, sickle cell, oral health, eye health, and all those similar conditions, as well as injuries. So on the part of AFRO, our key priority is ensuring that the regional targets are met, and it's great that this strategy is being launched, because it's looking specifically at across themes, surveillance, laboratory. It's not focusing on diseases, and we are hoping that it provides a platform to look at diseases and all the key NCD priorities in AFRO in a holistic manner without putting them in boxes. So when you develop systems for surveillance, it doesn't matter for which NCD it is. It just strengthens the surveillance systems across both sickle cell and cancers at the same time. When you strengthen laboratory services and diagnostics, it also does the same across diseases. So this is particularly very, very a welcome development. We also think that the issue about decentralization of care to primary health care is something that is pertinent in our region, as you've heard from all speakers in the, all day today. One of the key issues with in Africa is the limited human resource capacity. And so we will need to look for mechanisms and systems to be able to override this. And one of these strategies will be on decentralized care, especially for mental health and Ncds into PHCs. So having said all this, just to thank you once more, and it's our pleasure, and we are looking forward to working very, very closely with African CDC to support member states in ensuring that we are able to be the shining example across all the global regions in terms of implementing NCDs. Thank you very much.
No, thank you very much, and very good message there from the Regional Office for Africa. Looking forward to very concrete actions into the future. And now for WHO EMRO Regional Office.
Assalamu alaikum. Good afternoon, everyone. I'm Dr. Lamia Mahmoud. I'm the Regional Advisor for NCD Prevention in WHO Eastern Mediterranean Regional Office based in Cairo. And indeed very happy to be here and to be part of this meeting and congratulating Africa CDC on this achievement that they have made. I think Benti and Prebo have made it easy for me. They've spoken a lot of what we as WHO have been doing. I just want to highlight some key issues. And I think since morning, all the speakers have spoken about partnerships and how important they are. But I think we did not dwell enough on multi-sectoral action and making it actionable, moving from having just a mere buzzword and making it really something that's happening, because we know it's easier said than done, but it's critical to moving forward on the NCD agenda. And in the EMRO region, we've worked a lot on developing multi-sectoral action plans. But I think like other countries, we're struggling to implement them and to making the different sectors accountable and owning the strategies. And it might need some action that is at a higher level, whereby it's not the Ministry of Health that's leading these committees, but a higher body that will that all the ministries feel that they can report to. So this is something we need to think about. And earlier in Mamka's presentation, she shared that WHO is now collating experiences on multi-sectoral action. And in addition to Mamka's encouragement, I'd also encourage everyone, if they do have that good experiences to share that other countries could benefit from, it would be good if we got that information. Just to zoom in on EMRO region, we also have our vision, EMRO Vision 2023, that puts good emphasis on NCDs. And we also have a regional framework for action on NCDs that has 4 domains that focus on governance, prevention, and addressing the risk factors, health services, and the 4th one is monitoring and evaluation, surveillance, and research. So again, it aligns very well with the global NCD action plan that has now been extended to 2030. It aligns well with the priorities that we have seen today, and I'm very happy to see that. We look forward to working together and in areas where there are synergies through our respective regional offices and supporting as needed. In relation to working with CDC, before I joined the regional office, I was based in WHO Oman, where I also witnessed, I think, the establishment of a CDC office there. And hopefully through that, we can also establish and strengthen the linkages with CDC. Thank you very much.
No, thank you very much. Very good message around multi-sectoral action so that it delivers. And we are looking forward to sharing those experiences as we go along. So now I'd like to shift to other partners, and Dr. Ian Walker from the UK Department of Health. Let me say that because the name of the other agency is not clear which one it is. So Ian, please, if you can have the floor, please. Yes, sure. Come on.
Good afternoon, honourable ministers. Is that on?
The microphone is it on?
Thank you. Good afternoon, honourable ministers, ladies and gentlemen. It's a pleasure for me to be here. My name's Ian Walker. I'm a public health specialist from the UK government. And we've had the pleasure over the last 2 years of supporting Africa's CDC in the development of this strategy. And it's been our pleasure to be involved in that. I wanted to thank Dr. Mohammed for mentioning the team that we've had working on it over the last 2 years. I won't mention their names again, but it's been a great collaborative effort. This strategy was very much led by Africa CDC with the member states. Our role has been very much in supporting of that. So Africa CDC told us what they wanted us to do, and I believe that we've fulfilled that commitment and responsibility, and we're very pleased and proud to be involved in the plan as you see it today drafted, and we look forward to the next few days as we continue to refine it and ultimately complete the draft and approve and complete it. We wanted to also honour the leadership that Africa CDC has taken around this, particularly Dr. Nkengasong, Dr. Ahmed, and obviously Dr. Mohammed and his team. And clearly this is such an important area of work for the African continent. And so we congratulate Africa CDC on the leadership that they're demonstrating in this area. It's important for the future health and prosperity across the continent of Africa that NCDs, injuries and mental health are all tackled and addressed. The greatest burden of disease across the continent, in fact. And so with tackling these great public health challenge, then you are able to address some of the big health challenges that the continent face. We're looking forward to this strategy being finalised and validated this week. But I think we all know that in some ways the easy work has been done, and actually the hard work is yet to do over the coming years. And so we look forward to the efforts of Africa CDC, but also with member states. And it's been wonderful to be a part of this group today and over the coming days. This group of experts, like-minded colleagues who all know the importance of NCDs, injuries and mental health, and that we can collaborate with. So we look forward to ongoing collaboration and partnership with Africa CDC and to the future. And we hope that that will be a bright one. Thank you very much.
Thank you very much, Ian, for bringing us back to reality about the difficulties of implementation, even as we pass through this phase of validation. Now, I would like to go to Wellcome Trust. I had seen Becky online. Becky, are you online still? Beck Smith? I think she must have dropped off. As we look and see if we'll get her back online, we'll move on to Julian. Julian, if you can step up, please, and properly introduce yourself. You can use there as well.
Excellencies, Dr. Ahmed and distinguished colleagues from the Africa Centres for Disease Control, the many colleagues we've worked with at Africa CDC, and the many representatives here of member states of the African Union. It's a great pleasure to be here. I'm speaking actually on behalf of London School of Hygiene, Tropical Medicine, as well as CBM Global. I have two hats here today, and I'm particularly talking about the mental health work that's been done. It's been, for me, quite exceptional, the degree to which mental health has been an integral part of this whole process. And many of you will have noticed how well mental health has been represented even as we start our deliberations and as we go on over the next few days. I had the pleasure of participating in the Africa regional consultations around NCDs prior to the UN General Assembly meeting on NCDs in 2011. And at that meeting, African representatives there made a very, very strong case for mental health being taken forward to be a much stronger part of the subsequent meeting. Now, actually, Africa at that time was before its time, and it didn't particularly happen like that. But I got great encouragement from hearing Dr. Mohammed say earlier that as we started these consultations around NCDs in the Africa region for this strategy, it was countries, it was member states who said, and you must include mental health. The field of global mental health has absolutely exploded in the last 20 years. It's been a pleasure seeing so many good friends here who I've worked with over those years in mental health in many countries, and the strength of leadership coming from countries and in institutions like Africa CDC in mental health is wonderful to see. A recent study was published, which someone was talking to me earlier about, that showed that the amount of implementation of programs like MHGAP that are going on in Africa exceeds many other continents. So Africa is genuinely taking the issues of mental health on this continent seriously and finding its own solutions to resolving them. One of the things that we think a lot about in mental health is culture, and making sure that we can't just create global blueprints that are then implemented in countries, but they must be properly adapted, owned by countries and coming from countries. We've had some rich discussion already about the role of traditional leadership and how that intersects with the health system. One of the things that's been very strong, I think, about this process that we've been working on together is that the African public health institutions that are pertinent to supporting all member states in the African Union have been working very closely together on mental health. So at the London School of Hygiene, we're proud to be a part of a coalition, a consortium that includes Africa CDC in a very important leadership role, but also WHO Afro, WHO EMRO, the West African Health Organization, the East Central and Southern African Health Community, all the mental health leads of those groups coming together and talking regularly, carrying out research together and thinking about programming together on really key issues like health force strengthening, for example, which cannot be done independently of each other and should be done in a very coordinated way so that member states are best supported. That's all I wanted to say, really. I just want to close in thanking all the people who have been so collaborative in this work. I do particularly want to mention Sumaya, who's around, I think, who's done a lot of the work, and that's been very closely engaged with many of the different stakeholders, including service users who are pertinent to this work. We are really looking forward to hearing your deliberations and understanding better how the work that's been done so far can be improved upon. And as Ian said, and others have mentioned, it's the implementation that really matters. And is often where we fall down in health systems work. But we're really looking forward to seeing if we can continue to collaborate together as we move forward into action. Thank you.
Yeah, no, thank you. Thank you very much, Ian. And really, we are all looking forward to the next 3 days so that we can be able to go through this very important process of validation, and your partnership and support is really welcome. I think that's it. Yeah. One more. Okay. So I'm sure there are other still partners within the room, and as we go along, we will be able to share with the meeting here, the workshop here, the roles that we've been having. Let's go on with the presentation, and I would like to call on Miriam Sidibe to make her presentation. It is very important where we are headed for us to continually engage with the private sector because they do have a role to play. And Miriam, if you can introduce yourself, including your organization.
Thank you very much.
So that I don't make a mispronouncement of anything.
That's all right.
Miriam, please, the floor is yours.
Thank you very much. It's a pleasure to have been invited here today. So I'm a special guest of Dr. John Genkasau, and I was very honored that he would invite me to come and speak at this very important conference and workshop, which is going to define very much the future in terms of NCDs. A little bit about myself. So I'm Miriam Sidibe. Let's see how this thing works. Who am I? I'm a bit of a hybrid person. I'm from Mali. Welcome again to the state members. I'm an engineer. And then I ended up working first in refugee camps in public health, and then decided to do a doctorate at the London School of Hygiene and Tropical Medicine. Then joined Unilever and spent 15 years in marketing. I think for me, the most important part of today was just that it changed the way in which I could practice public health. And I wanted to share a bit of that. Is in terms of thinking what you could do with the force of the private sector in the industry. Because the industry is very often referred to as being the enemy around the table when it comes to NCDs. And today what I want to do is just get you to think a little bit about what we could do if we bring the enemy to the table. So that's the starting point of my conversation. So I have practiced my public health career mostly in the private sector, from a doctorate in public health to a marketeer. I have driven the world's largest hand washing program, having reached 1 billion people in over 35 countries, 5 continents. I was made an honorary professor of the practice by the London School of Hygiene and Tropical Medicine last year, in recognition of my work in hygiene over the last 20 years. So I left my work in Unilever about 4 years ago, joined Harvard as a senior fellow, and wrote a book around how to change those business models so that you could drive more health impact. And what can you do in terms of changing those business models so you could have both profits and purpose being led, mainly in health and well-being. I published that book. I've been joining boards. I started my own company called Brands on a Mission, who's a B Corp. For those of you who don't know what a B Corp is, it's probably the highest you can get in terms of a private sector trying to do good, basically. And just last year was named one of the 100 most influential Africans alongside John Genkasau. So a little bit around what I really wanted to talk to you about is just to get into thinking about this world that is basically rooted in terms of inequities, but then how these inequities and suffering can actually change when it comes to bringing what the private sector has to the table. I think all of us, and many of us in the public sector particularly, see the private sector as the source of CSR money, of checks that they're supposed to just hand over. And what I'm here to do is to get you to challenge a little bit that thinking and think about what could we do if we could get their innovations, their products, to change the way we practice public health? And what if we could challenge them to change that business model to see what we could do? So that is what Brands on a Mission is about. So I'm still trying to figure out what is the next way to move. We've already talked about data the whole day, so I won't spend a lot of time on this. You know this. Whether we're talking about 1 in 3 people suffering from malnutrition, the 14% of death worldwide attributed to mental health, HIV, and 1 child under 5 every 6 seconds dying, period poverty, which I don't think we talked about much, or sanitation, which is the background and the backbone of my own career. But what I want to talk to you about is what some brands and what some private sectors are doing about it. And it may not be perfect. And I don't want you to think that I'm here telling you this is it. They have all the solutions. The point is, today in this era where they're moving and they're thinking about purpose, and they really want to figure out whether there is an opportunity and a role for the private sector to rethink their business model to achieve the SDGs. What are some of those brands doing? And how much resources are they putting around on the table? And do we have a chance to shape those resources is the question I want to get back to you. So whether we're talking about those cubes that people are using and whether we're talking about fortifying them with iron, what are we doing in terms of getting them to translate and change the diets that people are having around the world, in terms of getting them to now eat more greens because it still has the taste that you want? You know what? We're talking about alcohol, and I know that's a very touchy subject here. And I'm going to talk to you a little bit about Carling Black Label, and I'm going to talk to you a little bit about the beer companies around the world, because the reality is they are culprits. There's no doubt in my mind, but they're also the biggest providers of potential solutions and portfolios, and they know where to reach the clients. So there's a lot of opportunities out there that I want to share a bit with you. Whether we're talking about condoms or soaps and what you could do with hand washing with soap, what we could do with obviously the ones making the pads, thinking about the change of norms, the stigmas, and everything else that we could do around that. So for me, the way I look at the SDGs when I speak to these companies, because that's what I do for a living, this is what I've done throughout my career over the last 20 years, is to convince these big multinationals that the SDGs are worth transforming their business model on. That in reality, if you look at only health and well-being, that there's an opportunity worth $1.8 trillion if they were to only align their business models to reach the SDGs. That new models of partnerships are going to be required for them to think about that. But those new models of partnerships are not about them handing over a check or just stopping at the time of taxations or incentives, because that's not enough. What's enough is going to be, what I'll take you through, is really finding that sweet spot where they can really benefit communities, and that trying to bridge the divide between what those companies are saying versus what they're doing. And this is what we try to do, is to try to bridge that divide so that you can infuse more ethics and values in the way marketing is done. And I know marketing has been seen as being a real culprit. But the truth is, we talked about culture, and I think Ian, who's also from my alma mater, from LSHEM, was talking about culture. But no one defines culture as much as marketeers. We buy brand, we live brand, we think about brand most of the time. So it's really important to think about what you can do. How can you change the world, one brand and one public health issue at a time? And what we want to do is to transform those business models in order to drive social impact and business growth for purpose. Not only to help them define this, but also to deploy their purpose. So now, today, obviously, I wanted to speak to you about, how can we support you? What is the best way? Because this is, it's a very unique skill set, trust me. There aren't many of me around the world, period, let alone in Africa, but my heart resides in Africa. I am African, I'm from Mali. It's pretty straightforward. My last name is very much a brand in itself in public health, if you know what I mean. But the point is there a way in which we could have this new public health order include partnerships that are transformational, that are really thinking about the private sector and what their rules are around the table? So that's the conversation that I wanted to bring in. I've been thinking about this for the last 20 years. I have published on Harvard Business Review. I've made covers of HBR on lessons for brands and what have they been thinking about global health challenges. My book is currently selling as the #1 business ethics book in the world, Brands on a Mission. I brought you a copy. I believe Dr. Mohammed, so you have a copy. I was part of the Lancet Commission on the Future Health of Sub-Saharan Africa. So I have been thinking about this. So don't get the motivation wrong, it's there. The motivation of transforming public health in Africa. But the motivation is to think about how you can use the muscle powers of what was once called the enemy in terms of rethinking their business model. But it's not about asking them to reduce their profits, because that's the wrong way to approach this. But for them to convince them that actually doing good is the most profitable way to do business. And this is what I wanted to quickly share with you. So for me, the way I see this is about how you address the risk factors from the business models, right? So we've talked today already about tobacco use, alcohol misuse, poor diet. we haven't talked too much about physical inactivity. We haven't talked too much about poor sleep. But the point is that the brands and the private sector have huge power to influence some of these risk factors through the product that they create, which shape our consumers' lifestyle, through the marketing they use to promote these products. So one of the biggest things we've ever done on hand washing was just to get the world's largest soap manufacturer to start thinking about hand washing before you eat and after you come out of the toilet. Just those two simple messages could make the biggest impact there was. And if you may want to watch my TED talk about that. The idea is around their ability to be able to address system-wide advocacy. They're a lot more engaging than us in the public sector. They know how to appeal to the consumer. And all of us are trying to get those lifestyle changes to actually change. So what can we do with these multi-sectoral partnerships that are going to be different? Again, we talked about, the iron cube fortified with iron. What can you do to get more women and girls in Nigeria and Kenya to eat their sukuma wiki with more spinach, with cubes? How can you get more kids to go to school every day with breakfast and add the fruits in there? Because they're going to be talking about breakfast anyway. So why not make sure that you're thinking about the meals and the dietary changes that are required at the right time? Yes, I know all about the products and I know all about the limitations. It's not like I don't know. I also know that products change and a lot of innovations have happened. Saturated fats have been gone. I also know fortification has happened. So I also know all of those as well. So whether we're talking about poor hydration and sleep, for example, and other risk factors, we talked today about CSD. We talked about carbonated soft drinks and kids having Coca-Cola like it's water. But what about getting the world's largest water manufacturer to start thinking about coming up with a demand-driven approach to get people to think that water is more cool, so that's the first choice that you take rather than CSD, right? What kind of behavior change and how do we make those social norms happen so that you could make those changes happen? How do we use this insect repellents, for example, to think not only about malaria control, but also about telling the consumer and helping them have a great night of sleep, because that is also a cornerstone to mental health, having a good night's sleep. Alcohol, and I know that's a very tricky one. And I almost thought this was going to be the end of my public health career when I started working with AB InBev. AB InBev is the world's largest beer company. I don't work with them directly, but they've come to me to advise them on the biggest agenda that they have. They wanted to spend $1 billion on the reduction of harmful use of alcohol. What they wanted to do was to see what they could do between now and the SDGs to think about their portfolio, to see what they could do to reduce our harmful use of alcohol. They're a beer company. They are the world's largest beer company, which means that so many of the brands that people drink are actually coming from there. And then, obviously they've done amazing partnerships. So there's a lot of work being done around road safety with UNITAR that has been translated in Kiswahili. But I think the most important thing was thinking about how you could articulate with them what you could do at policy level that's supporting the portfolio. What could you do with their social norms campaign to get people to not drink and drive, to get people to eat whilst they drink, to get people to avoid underage drinking, to get people to really think about reducing gender-based violence? How do you encourage them to start having a portfolio that reduces the percentage of alcohol content in beers so that you don't have any more beers that are above 3.5%? Because to say realistically, you're going to get people to stop drinking alcohol altogether might be too much. But to start getting people to have lower percentage alcohol might be one way to be able to reduce it. You may agree with me or not agree with me. The point is, they're there and people are buying the beers. So what are we going to do about that? What are we going to do to be able to rethink this portfolio, right? How do you make sure that we educate the consumers to be able to understand this alcohol health literacy? Because the biggest failure we've seen is that you could put all the literacy you want, unless it's communicated in the right packaging way, the consumer doesn't even read it, right? So I think this for me was something that was fascinating when I first started working with them on. That was my initiation to thinking about alcohol and what public health damage it was actually causing. And I started looking at some of their campaigns, and they have one of the biggest campaign around the reduction of toxic masculinity in South Africa called #NoExcuse campaign, which is basically getting all the soccer players and the sports to start saying there's actually no excuse for gender-based violence. They've done amazing PR as private sector knows how to do, only private sector knows how to do, to be able to bring that out there. But what it does is actually it creates the opportunity to be able to talk about a very sensitive subject and make it much more mainstream, which has to count for something. But we need to keep them accountable to actually, delivering impact and measuring. And that is where I come in, and this is where you come in, to be able to push that conversation so that we can figure out what more we can do with that. And we talked with a tea brand. I don't have much time, I can't share the video, but it's a beautiful idea that a tea is a moment, for example, where a tea moment is the moment where you could have a real conversation. And Joko, for those of you who know if there's any South Africans in the team here, and will actually tell you that Joko is such a big brand that puts together women. And what they wanted to do is to say, in the moment where you're drinking tea, can we use that opportunity to end the silence around domestic violence, just to get people to have a real conversation? But then we needed to partner with the right public sector so that you're not just opening up those conversations and there's no follow-up. So I think this is the part where the conversation becomes quite interesting to think about how you are supporting the social norms, the enabling environment, that are really creating problems for solving some of the issues that you're talking about. And what could the role of a tea brand be at all? The video is here, and I'm happy to share it later. But I'm aware that time is coming. But and again, that was Joko. Lipton has been on thinking and doing quite a lot around loneliness and reducing loneliness, and saying when you're drinking tea, this is an opportunity where you could actually reduce that loneliness. And they were one of the supporters and behind the friendship bench in Zimbabwe, for example, which is now being translated as well in Kenya. So quite a lot around mental health that can be done. I've done a lot of work on body confidence with Dove, mainly in other continents. But then, what does body confidence education for an African girl looks like? Because for us, this is the difference between being able to negotiate a condom and therefore, reducing your risks of HIV/AIDS. When we know that at the moment, there's 98 girls every week in Kenya being infected by HIV/AIDS. So these are young girls that do not have the opportunity and the confidence to be able to negotiate what happens next. There's many other aspects for that. What can we do to reduce the norms around toxic masculinity? Because toxic masculinity is very much at the center when it comes to reducing gender-based violence. There's no talking around that. That is the truth. What are you going to do when it comes to reducing or ending period poverty for all those who menstruate in Africa? So for me, engaging the private sector is an opportunity but we need transformational partnerships. The private sector can help tackle and has been a culprit of many of the other side of the same coin. And I'm very much aware of that. But the truth is they have a lot of resources at their disposal. And in the era where they're all thinking about the SDGs and they're thinking about the purpose era, what do you do to be able to transform some of this business model in a sustainable way? And they have the power to help drive many of these positive health outcome, of course. And instead of seeing the private sector as the enemy, I think we need to engage them. And doing so is going to help in many ways. It's going to help us together have a system-wide advocacy approach for more positive health outcome. It's going to make sure that communities have access to better health opportunities and products that are more suited as well. Because when we push the private sector to think affordability, accessibility, this is how you get products that actually ensures is reaching the poorest of the poor as well. And this is how we made the difference when it came to hand washing with soap. So there's no difference for us to start thinking about what else can we do with all these other products as well. And I think when you think about the youth in Africa, we need to also equip them to be a kind of consumer that makes better health and lifestyle choices. There's no reason to follow up what other continents have done. We could create a new generation that knows already, is going back, tapping into some of this indigenous food, is tapping in some of the drinks that we have already, and being able to push back what is actually coming and polluting our continent with what is actually not finding its way anywhere else anymore, when I'm talking about some of the fast food places. And thinking about new kinds of business models that, will drive social impact and business growth. So, I'm here a bit as a catalyzer. I'm here because I know how to work with the private sector. That's where I built my career over the last 25 years. And I have been working with many of the partners that you know already, whether it's UNFPA, we've developed how to guide on rethinking partnerships in the sexual and reproductive health. We've created a national business compact on coronavirus in Kenya, Uganda, and Tanzania to be able to drive some of the most innovative hand washing, and now we're going to do vaccines and hygiene messages mixed, with AMREF. I work with a variety of sector. I'm very much aligned with the academics. I'm still a senior fellow at Harvard Kennedy School. I'm aligned with the London School of Hygiene and Tropical Medicine. I get questioned a lot, but I believe that this is the right way to do it. And I believe that together, you can help me deliver on some of the evidence to drive this story forward, so that we could create a stories of impact that's based upon evidence, and that is not based only as a matter of rejection. Rejection when we don't see how you're going to be able to reach some of these products puts us in a place of, I don't think it's a very positive place that we are. So I'm based in Kenya. I operate globally. I am here to help, obviously drive catalytic private sector partnership. I'm around, it's my life passion, so I don't intend to go anywhere. Look out for my next book. I want to start having more of an impact on the African sector and the African continent. So I'm delighted that I have been invited here today. But I sure hope that this is only a very first nascent step towards something that's going to be more transformational. I'm open for every question, and I'm not scared of answering any of them. So I'm looking forward to continuing this conversation, and I would like to thank you once again for having invited me today.
Thank you very much, Miriam. Very thought-provoking for public health practitioners, and I hope they will come back with some good round of questions. And now I would like to invite. I can't see him. Usually he hides in a corner somewhere. Oh, there he is. Professor Jean-Claude Mbanya. I think he's been around for quite a while, so all of us know him. And he's going to take the other side of the conversation. How do we get non-state actors, particularly civil society, to be part of advocating for NCDI and mental health? Jean-Claude, the floor is yours.
Thank you very much. And I just want to thank the African CDC, their ministers and the rest for inviting me here. It's not often that they invite me these days. And I've been given a nice topic on the role of civil society in advocating for NCDs. In fact, when I look at this topic and when I received it, I thought of two things which are happening to me. In 2006, I was in the International Diabetes Federation, and we decided to have a World Diabetes Day. So we went to WHO and told WHO, let's get a World Diabetes Day. It was a stumbling block, but we got a World Diabetes Day. And today, since 2006, we've been celebrating the World Diabetes Day. When I became the president of the International Diabetes Federation in 2009, I decided that we needed an NCD alliance. The IDF created an NCD alliance, but we said we could not go alone. So we took cancer with us, we took mental health, we took cardiovascular diseases and the rest. Then we're not very satisfied. We said, let's go to the United Nations and have a high-level resolution on NCDs. So you can imagine my pleasure today when I hear that the African CDC is adopting the NCD. Why? Because as civil society, we have a role to play in order to catalyze the process. Power belongs to the people. As you heard the previous speaker, we did mention that during the high-level summit, that these private sectors are part of the problem of NCDs, and therefore they must be part of the solution. You cannot solve the NCD problem today without empowering the private sector. We thought we could emulate what happened in HIV/AIDS in South Africa when civil society raised their voices and advocated for what we have today as the UN TB, Tuberculosis Malaria Fund. That was a civil society movement. I wouldn't go into the needs of the NCDs because we've all been talking about it, and I noticed that most of you here have already cerebral hypoglycemia. So I will spare you what is on this slide. I only want to tell you that unless we frame the NCD questions in terms of health and development, we would fail. Because if you don't put development into it, we would fail because if I look at most of you here, it's all about the health sector. But NCD is not the health sector. It is whole of government approach. It is a health in all policy approach. It's a whole of society approach. It's not a health sector approach. NCD, the health sector, cannot solve how we build our cities, what children eat in schools, how we construct roads, how we label our food stuff, the imposition of food labeling. That is not the health sector. Most of NCD is outside the health sector. So we should learn to marry the other sectors and make it unique in the control of NCDs. I'm here to talk about civil society. Civil society, as defined by so many people, is a wide array of non-governmental, non-for-profit organizations that have a presence in public life, exercising the interests and values of their members or others based on ethical, and I've heard the word here, cultural, political, scientific, religious, philanthropic considerations. Therefore, civil societies refer to a wide array of organizations, community groups, tribal meetings, non-governmental organizations, labor union, indigenous group, charitable organization, faith-based organizations, and what we've always said, professionals, and especially the academics, since I am one of them, I must take credit to. What are the challenging landscape of the civil society? I gave you the brief history of from 2006, 2011. Now we have a significant growth in the number of diversity of civil society organizations, and they have been able to establish their roles and have had an influence to shape the agenda. We did that in 2011, and the African CDC is trying to shape the agenda as we move along. There has been a growing political recognition of the role and importance of civil society engagement. And now you see even in research projects, they start asking, how would you involve the community? How would you involve other organizations? And that is a plus for us because we can move forward. I use this map to show you that for the NCD Alliance, and credit to them for assisting me in everything as they have always done, has about a network of 66 nationals, regional NCD Alliance. And all of them have a common purpose. And sometimes people look at civil society as a unique entity. But inside, like NCD Alliance, you have people of mental health, you have cancer, you have tobacco, you have physical activity, you have all of them grouped together in what we call NCD Alliance. And they are united across diseases risk factors. They have legitimate voice of communities and people who are living with NCDs. And they have been recognized by the UN and other governments, as I mentioned in the subsequent slide. And they are building the demand for access to NCD treatment and care, which is in tandem with what the Africa CDC wants to do. Over the years, in 2018, the WHO Civil Society Working Group on NCDs, set by the current Director General, supported the preparations of the UN High-Level Summit on the one which came in 2018. And then, of course, we had the political declaration, and then we had the high-level summit, and now the World Health Organization Assembly extended the whole global coordination mechanism on NCDs mandate to 2030. And this was a movement, a convener of them were people living with NCDs to raise awareness and build capacity for a meaningful participation in NCD responses. It was 2021, 2022. We had ongoing consultations at the whole framework of meaningful people living with NCDs. And of course, in 2021, last year, we launched several activities with the various people, including mental health. I said yesterday that maybe by the time I leave from here, I will have a mental health disease, because I've never heard people mentioning mental health that I've done during these 2 days. What is the role of civil societies in the NCDs? And now I'm going into the nitty-gritty of the problem. There are 4 primary roles. And if you don't like my face, accept these roles, because that's what we do. There is advocacy, there is awareness, access, and accountability. It is our belief that a vibrant and strong civil society community capable of delivering its primary roles in advocacy, awareness raising, accountability, and the direct provision of NCD services is fundamental to reaching the global NCD targets. And this was in our action plan, NCD Alliance 2021-2016. Let's go 26. Let's go into some of it. Advocacy. And these are examples from the region. What we've tried to do is to get what is in the African region, national alliances with policies, landscapes, conducting. Kaushik is in the hall. Every time he calls me at past midnight to tell me that he has another meeting the following day on NCD Alliance Africa. Advocacy projects supported by national advocacy calendars. And I just want to give typical examples of civil society, including people with NCDs, which have been involved in decision-making processes. Rwanda's multi-sectoral coordination mechanism was led by the civil society. Ghana National Multi-Sectoral NCD Steering Committee. Kenya's Ministry of Health Intersectoral Coordination Committee on NCDs. And of course, the other examples are the Tanzania NCD Alliance with advocacy for the Parliamentary Forum on HIV, TB resulted in a new expanded forum on HIV, TB, substance abuse, and NCDs in July 2021. You've heard about the South African NCD alliances successfully advocating for soda tax in 2018, and is currently working in the human rights case presented at the South African High Human Rights Commission. You heard about the Burundians are here on NCD Alliance advocacy on the intersections between NCD and COVID, which resulted in the Ministries of Health inclusion of NCDs in the COVID-19 response. And you have regional perspectives in NCD Alliance network and other engagements involving who. And awareness has started, as I've said, raising awareness. We started with the World Diabetes Day. We go now into multiple avenues. We have media outlets. We have testing that we do to sensitize the public in terms of risk factors, in terms of know your numbers, know and treat. And these are slogans that we've used over the years in order to engage the community in terms of awareness raising. We have access, examples of access like training healthcare professionals. We've created helplines, screening initiatives, as I mentioned. And all this is involvement of the community, involvement of the people, so that they'll be able to know the risk factors for NCDs, which all of us are talking about. Accountability, we've gone into community monitoring, especially in Kenya, social accountability exercise led by people living with NCDs. We have monitoring of industry, and this is very important from the former speaker, signaling virtue, promoting harm, unhealthy commodity industries, and COVID-19. We have benchmarking of policies in progress, which are the civil status reports that we produce every time to sensitize the public and sensitize governments in order to promote a healthy NCD. We're also promoting meaningful involvement in the NCD response, which are the examples from this region. And I want to mention the second one, which is the African CDC Consultation in January 2022. And Mohammed did lead to that. And this was to do with people living with NCDs. Recently, as some of you would know, in February, there were 5 national advocacy agencies of people living with NCDs from Ghana, Kenya, Tanzania, Rwanda, Malawi, which was launched in February. We had regional contribution to consultative efforts to build the global charter on meaningful involvement of people living with NCDs. And over 15 endorsing organizations of the charter has so far signed in the African region. Ladies and gentlemen, we also enable factors for strong civil society. Civil society needs supportive, legal, social, political environments in order to thrive. And that governments throughout the region need to foster and expand civic space for civil society. There's a lot of investment which is needed, and we've heard of investment here, and we can be catalysts too of investment by provoking those who are part of the problem to be part of the solution through sustainably financing civil societies, community systems, especially in low middle income countries. The UN regional bodies and government needs to walk the talk, and that is part of what we've been doing over the years. Don't only talk, walk. And Dr. Kengason is here and your team. Be very careful. The civil societies would want you to walk the talk of this, what we are creating here. Are we creating a monster, or we are creating something meaningful which would engage everyone and everyone with NCDs? And this view of a civil society movement and people living with NCDs as equal partners and experts in their own right, and to create truly inclusive decision-making processes at all levels of policies and programs, which would design governance, service delivery, and accountability mechanisms. And these are important ingredients for success if we want to be successful. As I said from the very beginning, I see from your faces that you all have cerebral hypoglycemia. Some of you are seeing me double on this stage. Therefore, I have just said that the presence of a strong civil society movement in Africa is critical for achieving the progress and achieving what we are setting out today, what you would at member states would be setting out in terms of validation of what will be presented in front of you. But civil societies plays a key role in NCD prevention and control in 4 main areas which I've mentioned: awareness, advocacy, access, and accountability. And it will be the role of the civil society members to hold everyone accountable and see that they walk the talk. Civil society coalitions are valuable platforms to accelerate action. And if you work with the civil society, the growing network of national, regional NCD alliances across Africa region and globally is already a testament to this. And we're willing to collaborate with African CDC to make sure that what the embryo which you are bringing out today does not become a stillbirth. Governments and regional bodies must ensure a conducive enabling environment And this is to all of you who are sitting here representing your government. Don't come here and enjoy the food that I saw most of you eating, filling your plates here and having a hypoglycemia for cerebral because of your splenic vessels were filled with glucose absorption. This is an environment where you must take the message back to your ministers, back to your government, so that action is taken. We don't want the white paper, blue paper to stay in your cupboards. We want action. And this is because of action that we are here. I want to thank you very much. And I promise you that the civil society organizations are here with you and we will walk the talk with you. Thank you.
Thank you very much, Professor Mbanya. As usual, you always manage to keep all of us awake in a good way. And I think the message is loud and clear. Now, for this session, we are running significantly over time. And I'm looking for Mohammed so that we can see what next steps we can be able to take. It's 5:45. Maybe we will take only 2 or so questions. And then we can be able to close for today. And then from tomorrow, we'll continue with all the questions because all the presenters are still here. So if we can be able, so 1, 2, 3, and let's keep it at those 3. So we start with Nigeria, we'll go to Uganda, then I think that's Kenya, and then finally Botswana, and we call it an evening. So Nigeria first.
Thank you very much. Again, thanks to our really distinguished speakers. I just had a quick question for Dr. Sidibe. I'm trying to, have an open mind and engage with the new idea. My question really is how much I can understand the water companies, because you have a mix of people. But if we say, for example, alcohol and tobacco is not, but alcohol causes dose-related damage. And we are suggesting that if we somehow manage to get people to keep drinking but not drink and drive, that may be fine. Now, the question I have is, how is that different from, say, what was happening when tobacco companies were sort of trying to buy respectability by funding public health research or even giving money to good causes? The second bit is just a comment, just to highlight that personally at the NCDC, we have seen the benefit of engaging with civil society. It's interesting that he put up the 4 A's, but the part about advocacy and accountability is quite been beneficial for us because through the actions of civil society, we've seen direct increase in funding, commitments to health security, the health security agenda in Nigeria at both national and subnational government levels. Thank you.
Thank you. One very clear question and one comment. Uganda.
I want to thank the presenters, but I have a question with I'm sorry, I didn't get her name very well. The one who presented on the involvement of the private sector. I think we need guidance here. I think some private sector we can collaborate with, but others we should have a big no. A big no. We can collaborate with some private sector, those who are into banking, those who are into pharmaceutical companies, we can, but if you tell us to collaborate with people who are making cigarettes, who are making soft drinks, who are making beers, we need guidance, I think, from WHO, our technical advisors. I think we need to say a big no, even if they have all the resources under the world. There is a time when we must say no. It's not that I'm against private sector, but they are really who are against our health, and we should say a big no, not just because they have money, they have resources. There is where we have where there is a no-go area. And I think we should emphasize that from the beginning. I thank you.
Thank you, Uganda. Clear comment there. Kenya?
Thank you to the presenters. My question goes to Dr. Mohammed, and I'm seeking guidance on the finality of the 6 objectives, more so with the reflections that happened today morning and what came up that data monitoring, surveillance, and research is really a huge gap for our countries, most of the member states. I know it comes as one of the activities in the objectives, but I think I would have been happy to see it take its prominence as a standalone objective. Maybe you can comment on that. And the second is a comment in regards to the role of the public health institutes and NCDs. I think in most of the countries, they're first modeled in the country as responding to infectious diseases and outbreaks investigations. And indeed, when I told my director of public health that there's this meeting we are coming to, he told me that NCDs is not a priority at the moment. They are doing things in phases, and NCDs will come in phase 2 or 3. So I think in addition to increasing capacity, there's need to raise the priority of NCDs at that level. And I think that's an area CDC Africa can help us in. Thank you.
Thank you. Very clear. One question, one comment. Botswana.
Thank you very much. Mine is just a comment that probably I'll use the vehicle of advocacy here, that now CDC should advocate for mental health to be captured as, one would say, mental health in all policies, because it cuts across a lot of programs. Thank you very much.
Very clear proposal there. I'm sure Mohammed will ensure it is discussed during the next 2 days. So let's, in terms of responses, Miriam, you have 2 there, both very related.
Yep.
And then Mohammed, you have the one on the 6 objectives, and maybe you can touch a bit on the issue of the public health institutes and NCDs, the prioritization. And I think I would like, after all those responses, for Professor Mbanya to come back and touch a little on the issue of those who are part of the problem should be part of the solution, in a wisdom sort of a closure to the session today. So Miriam, Mohammed, and then Professor Mbanya.
Thank you very much. So to Nigeria, I think it's a very important question. So it's not about removing resources from the public health research and then thinking about now how you support either some of these campaigns or partnerships. I think both of them are complementary. My only push today in the conversation is, how do you get yourself to start thinking about pushing some of these whether these alcohol companies, at least the beer company. And there's a fundamental difference now that I've been working and thinking about this, about differentiation in, for example, in alcohol, right? So a drink isn't a drink. A glass of spirit is not a beer, and it's not the same percentage of alcohol. So it's about rethinking their business models where we can push them to start having more low alcohol percentage beer available, more no alcohol beer, for example, more spending on social norms campaigns that talk about reducing, partnerships with Ubers and Lyfts, so that, we make it a social norms that it's absolutely unacceptable to drive whilst drinking or having a drink. I think ultimately this is what I'm trying to think about. And I think it is their responsibility as well as ours to put that together, because we could put the policy all we want. But then, for example, some of the work that we've been doing with them is for every 2 beers that somebody is drinking in a bar, the third one becomes a glass of water or a bottle of water, right? And then, you open up and there's always a partnership, for example, with an Uber, where you get an Uber car and then if you've had 3 drinks, you can get in for free, for example, right? And all I'm trying to say is that, is there an opportunity to rethink how we work with, for example, a beer company, and you rethink about how we can put those messages of smart drinking, not responsible drinking, smart drinking, so that we can reduce those incidents of road injuries. We can reduce those incidents of underage drinking. We can make sure that it's unacceptable and that they're part of that conversations, and there is a real conversation with them around the table. So the research and the evidence needs to be there, because the truth is that, but if we keep pushing them away, you don't necessarily get to understand what is the opportunity that you could do. Because if you could get the beer portfolio to have 20% of their beers to have lower percentage of alcohol, that has to count for something. But I've yet to see the evidence to show whether that significantly reduces drinking. I don't know yet, but I know somehow it's something tangible to think about. But, and it's a big one for me. I am Muslim. I am from Mali, and I'm thinking about beer, and I'm talking during Ramadan. So I can tell you, like, it's a bit of a very interesting conversation here where I am, right? And it's not about, for me, the way I've decided and to work with the private sector is to get off my high horses of I only know and I save lives, and everybody else out there is wrong. Because I do believe that, yes, do we need guns industry? Not at all. Do we need tobacco? I don't think there's anything good that came out of that. And I don't advocate that we should do partnerships with tobacco industries, with guns, I don't advocate that. But I think that if you think about the food processing, there is a lot of very interesting things that food processing has done in terms of making our lives healthier in many different ways. So we just need to think about how you can work with them so that these billions of dollars that are spent in marketing could carry a little bit of good in them. Basically, that is my point. Now, of course, you could decide not to do that, but why not is my question.
Okay. Now, Miriam, very clear. And that particular conversation has been going on for a while. I think when a balance will be able to be achieved, I doubt it will be in my lifetime because I've spent 20-something years, working in the Ncds area, and I can see how the conversations go. But it's something that needs to be continued so that we reach some sort of balance that will accommodate the fact that public health has no replacement, and everything else needs to support public health. But a very good question that have come there. So Mohammed, on the objectives, and then we'll go to Professor Mbai.
And thank you, Dr. Ahmed. So we framed these 6 objectives as much as possible to be aligned with what Africa CDC is doing and what WHO is doing and what other partners are doing. However, we tried very hard to ensure that the key messaging on the new public health order is maintained. And if you look at the objective on enhancing the capacity of MPHI-MOH to integrate and implement national and supranational frameworks and policies for NCDI and mental ill health prevention and control. It talks, what you have here is just examples. It did not cover every. If you check in the document we've given you, it has all the high level activity and even sub-activities that we think should hold. So there you see surveillance, you see laboratory, you see pool procurement, and things we need the National Public Health Institute and MOH to do. We are quite aware that most mental health and NCDs are in Ministry of Health, but there are some selected things that the MPHI needs to do for now, even not something they need to do in future. Like you say, NCDI may be a priority for them in the future. For instance, in the Ebola response, we all know how the lack of mental health and psychosocial support was a big problem. And these are the institutions that are responsible for responding to emerging and re-emerging infectious diseases like COVID-19. In all cluster discussion in the Africa CDC EOC, psychosocial support was part of it, and for a very good reason. If you lose the support of the community because you do not cater for their mental and health and psychosocial support, you lose all the investment you've done in your emergency preparedness and response. So for MPHIs, it will be in their very good interest to work to strengthen their ability to do mental health and psychosocial support during response to emerging and re-emerging infectious diseases. And I think this has been enshrined in WHO documents, in fact, making that component a very prominent one for the case management cluster. Thank you. And yeah, I think that answered the MPHI component too. Thank you.
Yeah, thanks, Mohammed. Covers NPHI at all as well. And I think that the whole conversation around NPHIs and NCDs and mental health needs to begin now, particularly during this pandemic season, so that our directors of various departments can appreciate the importance of the whole NCDs conversation not being something we do tomorrow or next year. This is something that needs to go hand in hand with all the emergency, the health emergency work that we are doing. Professor Mbanya, please, for your wisdom.
Thank you very much, Mr. Chair. I've heard this argument so many times, and Gerard is an old broom in the house. You should know that meaningful engagement does not necessarily mean acceptance or partnership. About 15 years ago, we created Youth Ambassador for Diabetes, which is children with type 1 diabetes. They were so successful in South Africa that Coca-Cola company in South Africa gave us $3 million in those days, so that we should say Coke is not only a beverage, but can cure hypoglycemia. And it was 3 million. I sweated that evening, and the whole pressure was on me, but I said, no, we cannot do that. Then when we look at examples around the world where there has been meaningful engagement, like South Africa putting a soda tax or cigarette tax, and we look at what Mayor Bloomberg did in New York, where trans fats were eliminated, basically. And we look at what the mayor of San Francisco did several years ago, where they worked with the beverage company, and it was decided that no sodas will be sold around schools. Then we look at our children at home. I think the first thing in terms of a fight or engaging the industry is starting with our home, with our children. Why do we allow them to drink all this and we call ourselves medics? If we train our children to drink water, when they leave the house, they'll be drinking water. And that is the engagement. I think our engagement should be such that they are part of the problem and they should be part of the solution. And the only way for us to effect change, like what McDonald's or KFC is doing right now in Europe, offering vegetarian meals, vegetarian chicken, although we still have to assess, is because of the pressure that the Europeans put on them, and now they're changing what they have to do. So Gerard, my advice to you is that sit down with these companies, tell them we don't like what you're doing, and when they refuse, then put bold billboards that a cigarette will cause cancer and show pictures of people with cancer dying from cancer. And you'll notice that every time one takes a cigarette, because of the advertisement, they would put it down because of cancer. We have, as Professor Sidibe has said, we have means of turning the negative messages into positives. And that's what we should be looking for. How can we change the fact that the advertisement jingles that our children watch on TV has become the enemy of the good? People show you eat popcorn and you sit, and then you grow fat, you are obese, then you have diabetes, adolescent type of diabetes. Whereas we can change all this, and to change it means that we use that negative message, positive messages for indulgence into negative and negative messages, which means that we hold them responsible. And our governments and your governments here have a lot to do, and you have to assist us in this light. Health, especially NCD, is not only health, it is whole of government, it's a whole of society approach, and that is what we should live here with. Thank you.
Thank you, Prof. I think on that note, let me first thank you for being patient despite the hypoglycemia, for staying through until now. It's almost 6 o'clock. I think it is past 6. Second is to say that there's tea break right outside here so that we can fix some of those sugar problems that you're having before you go back to home or to the hotel. And third is to ask Secretariat to make some announcements about tomorrow. What time does it begin, and do we go straight into groups? And finally is the conversation around private sector, in which type of private sector will continue. And I hope that for the next 2-3 days that you're here, you actually get an opportunity to have that discussion. There's a lot of detail that needs to be unpacked, and it would be very useful that as you are looking at this strategy, you are also having that conversation around those who are causing the problem being made to be part of the solution. How to make them part of the solution, I think, is a discussion that we've been having, and I hope you'll have that opportunity over the next 3 days. So Secretariat, for tomorrow, what time do we start? And do we go straight into groups, or do we meet here first? Adela?
Thank you so much, Dr. Ahmed. So for tomorrow, we come at 8 to start with the rapid test. Since this is a recommendation to hold such meeting, and we convene here at 9 and we'll be presenting on the program of work for tomorrow. So we come here at 8 and start with the rapid testing. Then we come here at 9. Thank you.
Thank you very much, Adelad. Colleagues, excellencies, the meeting is adjourned. Let's meet tomorrow in the morning. Thank you.